Hello, everybody. Welcome to Ophthalmology Mastery Clinical Skills for MBBS students.
So in this video, we'll learn about examination of a case of pterygium. This is quite a common case that is kept for your exams. You need to know what are the how to present a case of pterygium and what are the common questions asked during the presentation. Okay, so the history. Obviously, the most common complaint would be a growth on the white part of the eye, which is extending to the black part of the eye, or a fleshy mass on the inner part of the left eye. Please don't present it as a tumor or a swelling. Okay, you have to present it as a growth on the eye on the inner aspect. That's you have to present it in the patient's words, right? Or a fleshy mass on the inner aspect of the eye growing onto the black part of the eye. Associated redness and foreign body sensation might be there. The patient might say that it is increases when exposed to dust or sunlight. So these will be the associated factors. You will ask whenever a patient comes to you with presents you with fleshy mass on the inner, you'll ask for the duration for how long it has been associated symptoms, and also you will ask whether there's any blurring of vision. Most often it might not be there, but some patients might present with blurring of vision. The causes, then the next question that the patient the examiner might ask you is, why would a pterygium present with blurring of vision? Most common cause is astigmatism. So it's usually against the rule astigmatism, where the horizontal meridian is more steeper than the vertical meridian. Okay, but if pterygium involves the pupillary area, like this case, it might be because of obstruction of the visual axis and resulting in opacity in the pupillar area, and thus reduced vision. Patients can, if it's a pterygium which is extending beyond the pupillary margin, beyond the temporal pupillary margin, and involving the temporal half of the cornea, they can present with restriction of movements and result in double vision. So this is a rare symptoms, but they can present with this. So you'll have to ask for the symptoms, right? Again, please remember, always the history starts, they notice the mass, and then these blurring of vision and double vision will start will manifest. It's not like blurring of vision starts first and then they notice the mass, right? So the common causes here, again, cause of reduced vision and pterygium, which would be blurring of vision and because of astigmatism or involvement of the pupillary area, double vision because of restriction of extraocular movements, or complications of pterygiums can also be asked. The most common is cystic degeneration or malignant transformation. Now on examination, so again you will present everything, family history, ophthalmic history, personal history, and then go to the examination. You will present, like in any other case, the whole order of ocular facial symmetry, ocular symmetry, and then present each eye separately, starting from the the eyebrows, the eyelids, and the conjunctiva. On conjunctival examination, we will describe the pterygium. Before you call it as pterygium, you will describe it as a conjunctival growth extending from the caruncle about 8 millimeter by 8 millimeter, extending onto the cornea about 5 millimeter across the limbus. You see, you will present it like that. Okay, the growth is fleshy and vascularized. It has a cap. In case if it has a cap, it has a cap in front of the pterygium, suggestive of a progressive nasal pterygium of grade 3. This is how we will present in the conjunctival examination. So a conjunctival growth extending from the medial end of the medial canthus, you can say, about 8 millimeter by 8 millimeter on dimensions, extending crossing the limbus and involving, always how much it involves the cornea is important, involving the cornea for 5 millimeter across the limbus, or reaching the pupillary margin or across the pupillary margin. And then you will describe whether it is fleshy, atrophic, vascularized, if there are any secondary changes, pigmentation, All those things you will describe, and then you will say it's a suggestive of a progressive nasal pterygium of grade 3, right? So the questions might be is what are the questions that might they ask? What is pterygium? Okay, you have to know it's a conjunctival degeneration with conjunctival fold extending on to the cornea. Right? What is the pathology of pterygium? It is elastotic degeneration of the subconjunctival tissue due to UV light exposure. Okay. Then what are the symptoms? What are the most common symptoms they might present with fleshy mass? Along with the most commonest reason that the patient comes to the ophthalmologist is cosmetic intolerance, cosmetic disfigurement, right? They can also present with foreign, if it becomes inflamed, they can present with redness, foreign body sensation, or blurring of vision is because of, as I already told, astigmatism or involvement of the pupillary area. What is the cause of reduced vision in pterygium is a very common question, and you have to say not only when it involves the pupillary center that it reduces vision, when it is away from the pupillary center also, because of against the rule astigmatism, it can cause reduced vision. Okay. Then the other questions that are asked is what are the types of pterygium? Okay, you need to know it can be a progressive or a atrophic pterygium. Progressive, as we already told, it can be vascularized, fleshy looking, and progressive in nature. Whereas an atrophic, it is thin, avascular. You hardly see any blood vessels on it, like in this case. And if you see clearly, you might see that there is a pigmentation line in front of the head of the pterygium that is called as the Stalker's line. When you see that, it's more of an atrophic pterygium, where it has progressed, reached one stage, and then stopped progressing. Okay, whereas progressive pterygium, you'll see some infiltrates in front of the head, and which is a suggestive that it is progressive. So, what are the parts of the pterygium? Parts of the pterygium is body, neck, head, and a cap if it is a progressive, and a Stalker's line if it is atrophic. So head is the part of the pterygium which is on the cornea. Neck is the part of the pterygium at the limbus, and body is the part of the pterygium on the bulbar conjunctiva. Please remember there's no tail, there's only body, neck, and head. Okay. Cap, which infiltrates, not the conjunctival tissue which is growing, but it is an infiltrate in the cornea. There's a corneal edema in front of the head, which is suggestive. If you see a cap, it is suggestive of a progressive pterygium. If you see a pigmented line, it is suggestive of a Stalker's line. Right? What is the commonest location of, next question is, what is the commonest location of pterygium? So most common is nasal. It's usually bilateral and it is nasal. Now the next question is asked is, why is it more common on the nasal conjunctiva? Okay, because of UV light. So the UV light usually hits the nasal bridge and gets reflected off the nasal bridge, and nasal part of the conjunctiva is the most commonly receives highest UV light. Okay, so that's why nasal bulbar conjunctiva is more predisposed to UV light damage, resulting in stem cell loss and causing a degenerative change, pterygium. Okay, so the other question, can a patient have pterygium on temporal or bulbar conjunctiva? Temporal bulbar conjunctiva. Yes, sometimes patients can have pterygium on both nasal and temporal bulbar conjunctiva. That time we call it as a double pterygium. Okay, so please remember, patient can have a temporal pterygium also, but usually when they don't have only on the temporal, they usually have both nasal. First is nasal being affected, then is the temporal. So usually it is a double pterygium. Then the next question is, what is the differential diagnosis of pterygium? So differential diagnosis of pterygium is pseudopterygium. So you'll have to differentiate pterygium from a pseudopterygium. Age of pterygium, usually pterygium is a degenerative condition, so it's seen in old age, whereas pseudopterygium can be seen in any age because it's usually because of a chemical or a mechanical injury. So it's more common in adults, young adults. Location of pterygium is always nasal because it's a UV light related to UV light, and it's a degenerative change. Whereas pseudopterygium can occur at any site. It can be inferior, it can be temporal, it can be superior, it can occur at any place. Okay. Etiology, again, pterygium is a degenerative, whereas here it is a chemical or a mechanical injury. progression, pterygium is progressive. So the patient, it's slow progression, but it is progressive. Patient might say they notice a small change, and now it has been increasing over years. Whereas pseudopterygium is stationary. Once there's a damage, there's a pterygium, there's a fibrovascular proliferation occurs, and it remains the same. It does not progress, right? Because there's no, the insult has been removed. Probe test. Okay, here we pass a probe below the head of below the neck of the the vascular tissue or the fleshy mass. In case of pseudopterygium, it can be passed, whereas in pterygium it cannot be passed because it's a subconjunctival tissue. So it is in pterygium it cannot be passed, whereas in pseudopterygium there's an attachment from the palpebral conjunctiva to the cornea. So there is in between there might be a free area where the probe can be passed. What is the next question that is asked is grades of pterygium. What are the grades of pterygium? So depending upon how much it involves the cornea. If it is less than 2 millimeter on the cornea, it is called grade 1. If it is 2 to 4, it is called grade 2. More than 4 millimeter, it is grade 3. But if it crosses the opposite pupillary border, it is called as grade 4. Okay. So you have to, once you tell that the location, the eye, the location, then the type of pterygium, whether it's progressive or atrophic, you will also have to talk about the grade of pterygium. Okay, that is your final diagnosis. So then the next question might be, so if you say there's a thing involving the limbus, so questions that might be asked is what are the causes of nodules at the limbus? Okay, so pingicula, pterygium, episcleritis or scleritis nodule, ocular surface commas neoplasia, or limbal dermoid. Then what are the complications of pterygium? Okay, the pterygium can undergo cystic degeneration or can undergo a neoplastic change. Usually it is a epithelioma or a fibrosarcoma. So these are the common questions that are asked when you present a case of pterygium. Right. Now, finally, you will give a diagnosis of it's a right eye, nasal, progressive pterygium of grade 2 or grade 3. So what is the management that we do for pterygium? If it is a very small atrophic pterygium, if you see a Stocker's line, patient is not bothered, patient is asymptomatic, you can leave it alone. No need for any treatment. But if it is inflamed, you need to reduce inflammation with topical anti-inflammatory drugs like flurbiprofen or topical steroids. If topical steroids are given at a tapering dose, flurbiprofen again, flurbiprofen eye drops for 4 times a day for 2 to 3 weeks, depending upon the inflammation. If the patient has only dry eye symptoms, topical lubricating drops are given, carboxymethyl cellulose eye drops. The surgical management is done if the patient complains of cosmetic disfigurement, if there's a visual disturbance, or if you see that there's a progressive pterygium and threatening to involve the visual axis, then you would want to treat it. Or if the patient presents with diplopia, you would have to treat it. So what is the surgical management? There are various surgical managements. The most common or the preferred one is pterygium excision with conjunctival limbal autograft. There's a pterygium extended removal followed by extended conjunctival transplantation, or called the perfect procedure. This is also pterygium excision with conjunctival limbal autograft. It's just that we do a extended removal and put a very large graft to prevent recurrence. Pterygium excision with amniotic membrane graft, pterygium excision with mitomycin C. There is also pterygium excision only where there's a Bayer's clear technique or Macronol's procedure. These are not done now, and you also need to know why it is not done. Okay, we'll see about that. So, why do we do? Why can't we do only pterygium excision? Why do we have to do conjunctival limbal autograft or amniotic membrane graft or mitomycin C? Mitomycin C is a anti-proliferative or anti-fibrotic agent. So why do we do that? To prevent recurrence. Okay, the most common complication after surgical management after excision is recurrence. So to prevent recurrence, you would have to cover it up with a conjunctival limbal autograft or a amniotic membrane. If there is a double pterygium, you won't have enough tissue of enough conjunctiva, so that time you would prefer a amniotic membrane graft. Okay, otherwise it's a or conjunctival limbal autograft. So it's from the same eye we take. Please don't say it is taken from a donor or from the other eye. From the same eye, from the superior. If you remove the pterygium from the nasal side, you from the superior aspect you take the same size of conjunctiva and transplant it. Okay, what is pterygium with extended removal followed by extended conjunctival transplantation of perfect procedure? Here, pterygium is excised from almost the superior rectus margin to the inferior rectus border, okay, and over the medial rectus, and a equally large graft is placed on the excised tissue to prevent recurrence. Okay. Now, how do we anchor? So, the other question commonly asked is how do you anchor these grafts? You can either anchor with sutures like Vicryl 60 or 80, nylon 90. You can also use fibrin glue. Off late, the same patient's serum or autologous serum is used, or where we just do a cut paste surgery, where we just cut the pterygium and paste the conjunctival autograft with just using the patient's own blood. Okay, the chances of graft displacement is there, but if the patient is well known and doesn't rub his eyes, these are also managed and shown to have good success rates. Now, why don't we do the question of why we don't do Bear sclera technique alone? Might also be asked because the sclera is avascular. So, if you leave Bear sclera, there's a high chance of scleral melting and uveal tissue prolapse. That's why we don't do Bear sclera technique, and chance of recurrence are also high. So, pterygium is no longer just excised. You have to say pterygium excision along with conjunctival limbal autograft. Macronol's procedure is a old procedure which was done earlier, where they used to cut the pterygium head, release it from the cornea, and place it in the inferior fornix. So the pterygium, even if it grows in the inferior fornix, but it's no longer done nowadays. But if if it's a old examiner who wants to know about whether you know about these procedures, you can tell about it. Okay. In conclusion, always describe the pterygium, the location, the eye, right eye or left eye, site, nasal, temporal, or double pterygium, whether it's a progressive or an atrophic pterygium, and finally the grade of the pterygium. Okay, indications for surgery are usually cosmetic, disfigurement, reduced vision, or progressive pterygium. Okay, and management is pterygium excision with conjunctival limbal autograft. So you have to know the management of pterygium, right? And complications of surgery are recurrence and medial rectus injury. That is the medial rectus can get injured during the pterygium, which is very rare, but it can occur. And recurrence if you don't do the surgery properly, if not excise the pterygium tissue, or you have not put the limbal autograft properly, there can be recurrence. So these are the common questions asked during pterygium case presentation, and you need to know about the etiology, the symptoms, and the management of a case of pterygium. Thank you very much.